This is Lecture 03, Adrenal Crisis, Hypoglycemia, and Hypercalcemia. These are Treat Now Endocrine Diagnoses. Adrenal crisis is shock plus steroid deficiency. Hypoglycemia is a bedside diagnosis with recurrence risk in sulfonylurea overdose. Hypercalcemia starts with fluids and ends with bisphosphonates. Waiting for confirmatory labs in any of these can kill the patient. The objectives are these. First, recognize adrenal crisis at the bedside and treat empirically with hydrocortisone plus fluids before lab confirmation. Second, manage hypoglycemia with weight-based dextrose dosing and glucagon when no IV access. Third, recognize sulfonylurea-induced hypoglycemia and use octreotide to prevent recurrence. Fourth, manage severe hypercalcemia with fluids first, calcitonin for rapid effect, and bisphosphonate for durable effect. Fifth, identify and treat triggers. And sixth, avoid the classic board traps. ED mindset for these endocrine emergencies is treat empirically. The cortisol level in adrenal crisis takes hours. The hypercalcemia lab is already known by the time the patient is shocky. The hypoglycemic patient cannot wait for fancy testing. Recognize the clinical pattern, treat the dangerous physiology, and look for the trigger in parallel. The right diagnosis with the wrong sequence kills. Adrenal crisis is acute glucocorticoid deficiency, often unmasked by stress. The classic features are hypotension refractory to fluids, abdominal pain that mimics surgical abdomen, nausea and vomiting, fever, fatigue, and altered mental status. Lab clues are the classic ITE quartet: hyponatremia, hyperkalemia, hypoglycemia, and eosinophilia, with an elevated bun on top. Mimics include sepsis, hypovolemic shock, hyperkalemic cardiac arrest, and severe hyponatremia of any cause, so the board pattern is shock that looks like sepsis but will not respond to fluids and pressors alone. Risk factors include known primary adrenal insufficiency, Addison disease, known secondary adrenal insufficiency from pituitary disease, chronic glucocorticoid use with abrupt withdrawal, Etomidate use, and recent surgery or infection in any patient on chronic steroids. The board concept is to consider adrenal crisis in any shocky patient with abdominal pain who is on chronic steroids or has known adrenal disease. Adrenal crisis treatment is immediate. The first-line therapy is hydrocortisone 100 mg intravenous bolus, then 50 to 100 mg every 6 hours. An alternative is hydrocortisone 200 mg continuous infusion over 24 hours. If the diagnosis is still pending and the cortisol level is being drawn before the first steroid dose, give dexamethasone 4 mg intravenously instead, because dexamethasone does not cross-react with the cortisol assay. The cosentropin, or ACH, stimulation test is an outpatient confirmatory study, not an ED step. Do not delay steroids for it. And in panhypopituitarism, give hydrocortisone before levothyroxine, because thyroid replacement first will accelerate cortisol clearance and tip the patient into crisis. Give isotonic crystalloid 1 to 2 liters initially. Treat hypoglycemia with dextrose. Correct hyperkalemia if severe with calcium and shifting therapies. Identify and treat the trigger. The board concept is to give steroids before fluids fully replete, because volume repletion alone does not reverse the cortisol deficiency. In a patient with known adrenal insufficiency, the two most common precipitants on the boards are infection and abrupt steroid withdrawal. After those, triggers include surgery, trauma, myocardial infarction, and gastroenteritis. In patients on chronic glucocorticoids, the body has suppressed endogenous cortisol production. Any stress event requires stress dose steroid increase, typically 3 times the maintenance dose. Failure to increase the dose during stress can trigger crisis. Etomidate, even a single induction dose, transiently inhibits cortisol synthesis. In a critically ill patient with marginal adrenal reserve, Etomidate can precipitate adrenal crisis. The board concept is to anticipate stress doses for chronic steroid users and to consider Etomidate-related adrenal suppression in the deteriorating septic patient. Hypoglycemia is a bedside diagnosis. Check glucose in every altered mental status patient, every seizing patient, every stroke-like presentation, and every diabetic patient with abnormal behavior. The threshold for action depends on context, less than 70 mg per deciliter in diabetics, less than 55 in non-diabetics with Whipple's triad. Whipple's triad is symptoms consistent with hypoglycemia, low measured plasma glucose, and resolution of symptoms with glucose administration. Memorize that triad. The classic mimics are stroke, seizure, alcohol intoxication, and sepsis. The board concept is that glucose is the first bedside test in any neurologic deficit, and the classic distractor is the focal stroke-like deficit that resolves with an AMP of D50. In the alcoholic or malnourished patient, give thiamine 100 mg intravenous before or with the dextrose to prevent precipitating Wernicke's encephalopathy. Hypoglycemia treatment depends on axis and severity. With intravenous access in adults, give 25 grams of dextrose, which is 50 milliliters of 50% dextrose, intravenous push. In children, give 2 to 4 milliliters per kilogram of dextrose, 25%, Oregon 5 to 10 milliliters per kilogram of dextrose, 10%. In neonates, use dextrose 10% at 2 milliliters per kilogram. Without intravenous access, give glucagon 1 milligram intramuscular in adults or 0.5 milligram in children less than 25 kilograms. After recovery, give complex carbohydrates orally to prevent recurrence. The board concept is dose to weight in children and use glucagon when no IV access is available. Sulfonylurea-induced hypoglycemia is a classic board trap because it recurs. Sulfonylureas, glipizide, glyburide, glimepiride stimulate insulin release from pancreatic beta cells. Dextrose corrects the immediate glucose but stimulates more sulfonylurea-driven insulin release. The patient becomes hypoglycemic again hours later. Glyburide is the longest-acting offender, with effects lasting up to 24 hours, so a single dose can cause repeated hypoglycemia long after dextrose correction. The antidote is Octreotide, a somatostatin analog that suppresses pancreatic insulin release. Dose is 50 to 100 micrograms subcutaneously every 6 to 8 hours, or as an infusion at 25 to 50 micrograms per hour. Patients with sulfonylurea hypoglycemia require admission for observation, even after glucose corrects. The board concept is that sulfonylurea hypoglycemia plus dextrose alone equals recurrent hypoglycemia. Add octreotide and admit. And beyond medication overdose, hypoglycemia causes include sepsis, alcohol use disorder with prolonged fasting, adrenal insufficiency, severe hepatic dysfunction, malnutrition, gastric bypass with dumping syndrome, insulinoma, and beta blocker overdose blunting symptoms. Each requires source-specific evaluation. Alcoholic hypoglycemia in particular can be missed when the patient appears to be just intoxicated. In any alcoholic or malnourished patient, give thiamine 100 milligrams intravenous before or with dextrose to prevent precipitating Wernicke's encephalopathy. The board concept is that hypoglycemia is a symptom, not the disease. Always look for the underlying cause. Hypercalcemia is recognized through the classic mnemonic stones: bones, abdominal groans, psychiatric overtones, stones, nephrolithiasis, bones, bone pain and pathologic fractures, abdominal groans, nausea, vomiting, constipation, pancreatitis, peptic ulcer disease. Psychiatric overtones, confusion, lethargy, depression, coma. Add polyuria from nephrogenic diabetes insipidus and dehydration. The classic ECG finding is a shortened QT interval, and severe hypercalcemia can produce Osborne-like J waves and bradyarrhythmias. The most common cause in the outpatient setting is primary hyperparathyroidism. The most common cause in the hospitalized or ED patient is malignancy, often bone metastases or paraneoplastic PTHrP secretion. The board concept is that severe hypercalcemia with calcium greater than 14 milligrams per deciliter is an emergency. Severity guides urgency. Mild hypercalcemia is calcium 10.5 to 12 milligrams per deciliter, often asymptomatic. Moderate is 12 to 14 with variable symptoms. Severe is greater than 14 with severe symptoms or coma. Always check ionized calcium and corrected calcium for albumin. Triggers and aggravators include thiazide diuretics, lithium, vitamin D toxicity, immobilization, and milk alkali syndrome. Recent diuretic exposure or immobilization can push moderate hypercalcemia into severe. The board concept is that calcium greater than 14 needs aggressive treatment, regardless of cause. Hypercalcemia treatment is sequential. Fluids first. The patient is profoundly dehydrated from osmotic diuresis. Give isotonic crystalloid 200 to 300 milliliters per hour, totaling 4 to 6 liters over 24 hours, with cardiac monitoring. Loop diuretics like furosemide are no longer routine and should only be given after adequate volume repletion, never as the first move, and only if pulmonary edema develops from over-resuscitation. Avoid thiazides, which worsen hypercalcemia. The board concept is that fluids alone can lower calcium by 2 to 3 milligrams per deciliter, and they buy time while more durable therapies start to work. After fluids, calcitonin for rapid temporizing effect. 4 international units per kilogram subcutaneously or intramuscularly every 12 hours. Calcitonin works within hours, but tachyphylaxis develops within 48 hours. Then bisphosphonate for durable effect. Zoledronic acid 4 milligrams intravenously over 15 minutes. Oregon pamidronate 60 to 90 milligrams intravenously over 2 hours. Bisphosphonates take 2 to 4 days for full effect, so the sequence is fast-acting calcitonin to bridge while the slow-acting bisphosphonate ramps up. For refractory cases or contraindications to bisphosphonates, Denosumab 120 mg subcutaneously is an alternative. Glucocorticoids are useful in vitamin D toxicity or hematologic malignancy. The board concept is sequential therapy: fluids, calcitonin, bisphosphonate. Dialysis is reserved for severe symptomatic hypercalcemia in patients with renal failure who cannot tolerate fluid loading, in calcium greater than 18 mg per deciliter, or in calcium toxicity refractory to medical therapy. Hemodialysis with low calcium dialysate rapidly removes calcium. Nephrology consultation is essential. The board concept is that dialysis is the rescue for the patient who cannot be fluid resuscitated or who has extreme calcium levels. Disposition depends on severity and trigger. Adrenal crisis requires ICU admission with endocrinology consultation. Sulfonylurea hypoglycemia requires admission for octreotide and observation, typically 24 hours minimum after dextrose-free euglycemia. Severe hypercalcemia requires admission, often telemetry, with cardiology and nephrology involvement as needed. Symptomatic hypoglycemia in an insulin-treated diabetic without sulfonylurea exposure may be discharged after resolution with a teaching intervention and follow-up. The board concept is that adrenal crisis and sulfonylurea hypoglycemia are always admissions. Glucagon is useful in 3 settings. First, hypoglycemia without IV access, 1 mg intramuscular in adults, 0.5 in children less than 25 kilograms. Second, beta blocker overdose with bradycardia and hypotension, 5 to 10 mg intravenous bolus, then infusion. Third, calcium channel blocker overdose alongside other therapies. Glucagon has minimal benefit in alcoholic or chronic malnourished patients because of depleted glycogen stores. The board concept is that glucagon is a tool for selected patients, not a universal hypoglycemia antidote. Etomidate, the common emergency department induction agent, transiently inhibits 11-beta-hydroxylase, reducing cortisol synthesis for up to 24 hours after a single dose. In otherwise healthy patients, this is clinically insignificant. In septic patients or those with marginal adrenal reserve, even a single dose can contribute to adrenal insufficiency. The board concept is to consider etomidate-related adrenal suppression in the septic patient who deteriorates after intubation. Some protocols give a single dose of hydrocortisone after etomidate use in septic shock for this reason. The board traps are predictable: waiting for cortisol levels before treating suspected adrenal crisis, giving dextrose alone for sulfonylurea hypoglycemia and discharging the patient, discharging a sulfonylurea hypoglycemia patient who has corrected, using thiazide diuretics or aggressive furosemide for hypercalcemia, starting bisphosphonate before adequate volume repletion, forgetting to give stress-dose steroids to chronic glucocorticoid users undergoing surgery or facing acute illness, anchoring on alcohol intoxication and missing alcoholic hypoglycemia, and missing the trigger for any of these conditions. The cortisol level is the wrong thing to wait for. Case 1. A 50-year-old with rheumatoid arthritis on chronic prednisone develops nausea, vomiting, and abdominal pain after stopping prednisone abruptly 3 days ago. Blood pressure is 85/50. Sodium is 128, potassium is 5.7, glucose is 60, and the differential shows eosinophilia. That is the classic ITE quartet: hyponatremia, hyperkalemia, hypoglycemia, and eosinophilia. The correct approach is hydrocortisone 100 mg intravenous immediately, followed by isotonic crystalloid 1 to 2 liters, dextrose for the hypoglycemia, and an infection workup as a possible trigger. Resume baseline prednisone and educate about never stopping abruptly. ICU or step-down admission with endocrinology consultation. The board trap is fluid resuscitation alone, which fails to address the cortisol deficiency. Case 2. A 70-year-old with type 2 diabetes on glipizide presents with confusion and a glucose of 35. After 50 milliliters of dextrose 50%, glucose rises to 140 and mental status improves. 3 hours later, glucose drops to 50 again. This is sulfonylurea-induced recurrent hypoglycemia. Start octreotide 50 to 100 micrograms subcutaneously every 6 to 8 hours. Admit for observation, typically 24 hours minimum. Hold the sulfonylurea. Counsel about medication adjustment. The board trap is discharging after the first correction. Case 3. A 65-year-old with metastatic breast cancer presents with severe lethargy, nausea, and constipation. Calcium is 18 milligrams per deciliter. Corrected calcium is similar. The patient is profoundly volume deplete. Treatment is isotonic crystalloid 200 to 300 milliliters per hour. With cardiac monitoring, calcitonin 4 international units per kilogram subcutaneously every 12 hours for rapid effect, and zoledronic acid 4 milligrams intravenously over 15 minutes for durable effect. Avoid furosemide unless pulmonary edema develops. Admit for monitoring, oncology consultation, and consideration of dialysis if refractory. The board trap is giving furosemide routinely or starting bisphosphonate before adequate fluids. Question 1. What is the first-line ED treatment for adrenal crisis? The answer is hydrocortisone, 100 mg intravenous immediately, followed by isotonic crystalloid, steroids before full volume repletion. The board trap is using dexamethasone unless cortisol is being drawn first or giving fluids alone. Question 2. What is the antidote for recurrent sulfonylurea-induced hypoglycemia? The answer is Octreotide, 50 to 100 micrograms subcutaneously every 6 to 8 hours, alongside admission for observation. Dextrose alone is not enough because sulfonylureas drive continued insulin release. The board trap is discharging after dextrose correction. Question 3. What is the first treatment for severe symptomatic hypercalcemia? The answer is isotonic crystalloid volume expansion at 200 to 300 milliliters per hour. Fluids alone can lower calcium 2 to 3 milligrams per deciliter and prepare the patient for additional therapy. The board trap is starting bisphosphonates or furosemide first. The final takeaways are these. Adrenal crisis is shock plus steroid deficiency. Give hydrocortisone first, then fluids, then trigger workup. Hypoglycemia is a bedside diagnosis. Use weight-based dextrose in children. Glucagon when no IV access. Sulfonylurea hypoglycemia recurs unless octreotide is given. Admit for at least 24 hours. Hypercalcemia treatment is sequential. Fluids first, then calcitonin for rapid effect, then bisphosphonate for durable effect. Calcium greater than 14 is severe and requires aggressive treatment. Always look for the trigger, and in patients on chronic glucocorticoids, anticipate stress dose increases for any acute illness. Confirmatory labs are rarely the right next step. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the Endocrine Society Guidelines for Primary and Secondary Adrenal Insufficiency, the American Society of Clinical Oncology Guidelines for Cancer-Associated Hypercalcemia, the American Diabetes Association Recommendations for Hypoglycemia Management, and case literature on sulfonylurea-induced recurrent hypoglycemia and octreotide use. Local institutional protocols for ICU admission criteria and endocrinology consultation guide site-specific decisions.